Can FAVA be accurately diagnosed if a patient just walks in and goes and sees a doctor, has an exam, has an MRI, or do they really need that biopsy in order to get an accurate diagnosis?
I think all the questions are going to have caveats or exceptions to the rule. We do feel that the combination of history, physical exam, and MRI is sufficient, particularly if the FAVA is a sort of focal or just in one area, one that has all the usual findings. If there's something unusual, we may still recommend a biopsy. And sometimes what I'll say for my patients, particularly a surgical biopsy is a procedure and an anesthetic. So if you have a focal lesion that can be removed, well, anyway, it may make more sense to do what's called an excisional biopsy, which means that you're testing the tissue by taking out what you see.
You have a patient that comes in. How do you decide whether they need a partial resection versus a total resection, assuming they qualify at all?
FAVA is a diagnosis that really needs individualized treatment. So the first thing to say is, what are your goals of treatment? And I just had these discussions this afternoon, and it's really someone's individual quality of life. Like, are we improving it? What are their goals? So if someone has a fairly functional, say, arm or leg, most FAVAs are in the leg more than arm, but they're in an extremity. They may not want a complete resection, which means an amputation, if they can have a functional limb and less pain with a partial resection. So, it really depends on the type of lesion. Some are very well demarcated, circumscribed, like a little ball that you can get around. Some are we call very diffuse. So they're through much of a part, and they may involve nerves, major nerves to your arm or leg. And so if you do a complete resection, it may be a worse functional outcome for the patient. FAVA is not cancer. It's not going to spread elsewhere. It's not life-threatening. Well, I tell my patients I'm trying in most cases to do a radical resection, which means taking the entire thing out as well as a cup of normal tissue. In some cases, doing that would involve like taking away, say, the major nerve to the leg, which is called the sciatic nerve. Often we'll say, we think resection will be helpful, but it won't be a complete resection. And instead, we would perhaps offer also other treatments. So that's where I'm sure we'll get to that later on, where some patients need combination treatments of both medical therapies, surgeries, and maybe the injection therapy, sclerotherapy, and the freezing therapy, which is cryotherapy.
Is it accurate to say if you do a partial resection and you cannot take out the complete lesion, that they will need other treatment like medication?
Well, it's not like sometimes, not always. So if it's symptomatic and causing problems, yes, but sometimes we say, we know, like I'll do a muscle resection and say, I know there's some nerve involvement, some things I couldn't take out, but if the patient is doing well, we may just observe that. We do see a lot of people who come in and they could have had a more complete resection, but someone didn't want to go into the deep tissue or muscle. Mm-hmm. And in general, we would tell FAVA patients that's not too helpful. If you sort of just scratch the surface of the lesion, it's like the tip of the iceberg. You sort of just take the part you can see right under the skin and out, and you don't address the deeper disease, that probably is not going to help.
Okay. And can you tell in advance how helpful a partial resection might be?
Well, I think we are getting better at it, of trying to, again, individualize that treatment to say what might be best for someone. But that's is very important if a patient know going into it, what's their chance of, a complete recovery, never having to worry about it in the future and never needing other treatments, or the chance that they will need ongoing treatment in the future.
Okay, so next question. So you have a patient and they come to Boston and you guys say to them, you qualify for cryoablation and you qualify for resection. In your opinion, what should they do?
Well, I'll be perfectly honest, we do shared decision making. Dr. Shake's therapy, what I always say to patients is it's minimally invasive. It still requires an anesthetic, but it's a little needle. Whereas even the small ones I take out require an incision, and some of my incisions are very long. So there's going to be a longer surgical recovery of like wound healing and then physical therapy with my procedures. And also there's going to be a scar. If someone has a fixed, tightness or contracture, particularly if it's around a joint, like near a knee or an ankle or an elbow, we do tell them that the cryotherapy will not make that better. Because what the cryotherapy is doing is freezing the FAVA tissue, which can sort of kill it by freezing it with ice. But then it's sort of a scar ball. And so that also won't stretch. But again, it's shared decision-making of what's best for each person. All the treatments are interchangeable. There's no evidence in my papers that there were worse outcomes for people who had had cryo before surgery, sclerotherapy. Some people had many treatments. The only thing that predicted a poor outcome was direct nerve involvement.
Okay, so if they walk in and they say, if I have one cryo or resection, it doesn't work and I want to have the other, then you don't suggest they do one before the other?
Nope, not presently. We give them, our description of how it works and what the recovery is, and then, go through what their exam and problem is. The other thing I think Dr. Shake will say about cryotherapy, because again, there you're trying to freeze the affected tissue, is that if there's a really large lesion, he just can't safely freeze it all. So he can speak more to that because I don't know his particular limits, but some of the tumors I've taken out are like bigger than footballs. Yeah. And so if it's that big, he just can't freeze it all. And we may say to patients, it's better to kind of get rid of the mass. And then if you have a small area later, you could always have cryotherapy. The other reason we don't pick cryo is if the lesion is stuck to major nerves and vessels. And in that case, it may seem odd, but it's actually safer to make an open incision and carefully dissect or take the FAVA away while surgically protecting the nerves and arteries and veins than it is to kind of freeze the whole area. Because nerves don't do well with freezing. If you've grown up like in a cold climate and had frostbite and had like your fingers like totally go numb, that may make some sense that you don't actually want to permanently freeze a nerve because then it just doesn't work.
And what are the risks of nerve damage when going in for surgery, like a resection?
Well, any procedure has a risk. Always someone should tell you a risk of infection, bleeding, nerve injury, and adjacent structure injury. I think with open surgery, what we found is it's very low, but it can occasionally happen that during, especially if the FAVAs tend to be really stuck. And so it can happen. It's been fortunately a rare event. And most of the ones that I've seen have been temporary, like the nerve has kind of been asleep after surgery and then woken up. But we typically tell people it's about a 1% risk. And we can tell you, we again have to individualize because some FAVAs are nowhere near a major nerve, and a lot of patients I see have been told they can't have surgery because it's too dangerous because the FAVA is too close to the nerves and vessels. But in our hands here, we may feel that we could do it, and we have done it safely.
And so if someone does get nerve damage, whether it's from the surgery or just permanent nerve damage from the FAVA, and they have the resection, what can they do about the nerve damage after the fact?
The first thing is you have to be really honest about why the nerve isn't working. So for some patients, just in the exam room and based on the MRI scan, we know that the FAVA is actually involving their major nerve. It's very important to tell somebody that, like, look, based on your scan and your exam, you're really having nerve symptoms. And when I've looked back, those people, again, have the highest risk of not having a good outcome, meaning that their pain is not much better, or even in some cases it's gotten worse. So that's the number one. It's like you should be able to tell up front before you have surgery or cryo whether someone already has nerve damage. And then after a procedure, if someone had a change in nerve function, then we want to say, like, why and what do we expect for recovery? The most common thing that happens after surgical procedures is that the nerve goes to sleep. That's called a neuropraxia, that just from time and pressure and all of the movement of the nerve while we're doing our procedure, it stops working for a while. And those have a very high rate of recovering naturally, just with time. But it can take months.
Okay.
So sometimes I'll say to patients, like, if something's kind of numb when they first wake up, but I say, look, I have pictures of your surgery. We know the nerve is in continuity. Like, we have pictures that it was not damaged. So we just think it had this neuropraxia, went to sleep, and it's just going to take time to wake up. And then there are times that during a procedure, you think the nerve got damaged. And then you have to decide, does someone need a further procedure to repair it? There are occasions where we know that we cut something during surgery and we repair it. You know, if you cut a major vessel or nerve, then you're going to repair it right then and tell someone. But sometimes it's a combination. You know, sometimes in surgery, I will know that the nerve is in continuity, but also see that it has involvement. And then we'll sit down and talk to the person and say, well, you know, let's wait and see a while. It's important to say what's the degree of nerve damage. So sometimes, like one of the patients I saw this afternoon, sometimes it's just a little bit of numbness.
Yeah.
And that may not be too bothersome to someone. Sometimes we purposefully, like for my resections, I'll tell patients up front that if I see a skin-based nerve that just provides sensation and it is really diseased and involved with the FAVA, I will resect it, because it's never going to work and it's just going to be painful. And most people would much rather have a small area of kind of dull or numb sensation than a super throbbing, painful area.
Yeah.
So it's just a lot of like, if this, then that.
Yeah.
I think overall, what we've seen is there's a very low rate, but you should never say never, of surgical complications with any type of procedure of cryo or sclero, but we typically say it's about 1%.
Can you walk me through the healing process after resection? What should a person expect in terms of how long it takes? Do they need to do physical therapy? What's the entire process?
Well, again, that's variable on how big it is. But if it's a fairly sizable one in the leg, like the small ones are a couple, you know, if it's a small lesion, it's a couple weeks for the wound to heal. But typically I'm telling people in a major resection of an arm or a leg, everything is sewn up with dissolvable stitches. You usually have a drain tube for at least a few days. You have your block catheter to keep everything nice and numb, which we found extremely helpful. And then we typically keep somebody wrapped up and splinted, often for 3 to 4 weeks, like most of the first month. And so we do not start really early strengthening therapy. Someone can mobilize, like they're usually, if it's a leg, they're up on crutches and getting around, but we want everything to heal first. And then typically for an open resection at a month, things are well healed. And then you start seeing a therapist and working on range of motion and strengthening. And for a major resection, I tell patients it's often 3 to 6 months.
What type of patient could you say to them, this should be a complete recovery, pain-free, no more treatments?
So I think we are learning that with confidence. I've got to finish this other last paper, but if you have a focal resectable lesion where I can really get around it, or another surgeon like me, we know that surgery works really well and people typically don't have recurrence. Dr. Sheikh, of course, will speak to the cryotherapy data. But if you have a very widespread lesion where we can't sort of take it all out, then we tell people they will need ongoing treatment. And then it's that decision of what's best.
So if I'm a patient and I walk in and it is focal and it is isolated and you remove it, can you say with confidence, okay, you're FAVA free forever?
We don't know forever, but at the what we call midterm follow-up of 5 to 10 years, it's really looking like those folks don't have disease come back.
Okay.
So those have the best chance, clearly. Now, as we get more long-term follow-up to really say, are those people really for life disease free? But I think there are a lot of parallels to cancer, right? I often will say to people, you know, if you have, say, a skin mole that's a melanoma, you catch it early, you can take the whole thing out, then you're usually done. And it's very similar in FAVA. If you have a focal lesion that's causing, well, enough symptoms to justify surgery, if it doesn't cause any problems, you may choose to observe it. But most people come in with, you know, pain, contracture, limping, trouble using their arm if it's in their arm. we really can say with confidence that if it's focal and resectable, you can have a really good return of function and high chance of never having a problem in the future.
Do you have any idea off the top of your head how many patients you've done resection in that like 5 to 10 year post range now?
It's got to be over 100.
Do you know how many patients you've done surgery on total?
No,
clue?
it's probably getting close to at least 200, I would say. But again, we're going to have to definitely somewhere, I think, between 1 and 200. I think we're getting a better evidence-based picture, which certainly I want to share with patients.
And then also, can you define the terms focal and contracture?
Sure. Focal means just in one area. So think of it like, again, like a discrete little ball or in one muscle group. That in diffuse means kind of spread out, infiltrative through multiple parts and areas. So as we get further into our research, I think we are learning that really matters, whether someone has a disease that's kind of like got very clear borders versus something that is hard to say exactly where it starts and stops.
Okay. And if they walk in with a symptom of contracture, what is that?
Yeah, that's a really good one to define. Contracture means a fixed tightness. So most people are familiar, when your muscles feel tight, you stretch them. But what we found, particularly with FAVA and muscles, is that the tightness is fixed, like you can't stretch it. And what I say to people is it's because it's not normal, flexible muscle. It's this fibro-adipose tissue that is not going to respond to typical stretching. So for example, in the leg, one of the most common areas is the back of the calf. And many patients come in toe walking, like they really can't get their heel down. Sometimes they've even had surgery to try to stretch their Achilles when the problem was up in their muscle where the FAVA was. That's something we found, that if the diseased muscle where the FAVA is the problem, if you take it out, I can confidently say that the contracture goes away. And we've shown that like 97%. You can never again say 100, or it's usually wrong, but 97% is the number in my surgical series so far that get better once you take away the FAVA.
So let's talk about situations where someone might need medication after a resection. So we talked about it's probably a partial resection where you couldn't get the entire thing. It wasn't focal, it wasn't isolated. What should they expect in terms of medication? Is there a certain amount of time they need to take it, or is it forever? How does that process work?
Well, I'll try to give the basics, but my hematology colleagues are typically who would prescribe the medical therapies for vascular malformations. Most vascular malformations that need medication are more widespread. We do think of them as being lifelong. So I often say to someone, it's similar to having high blood pressure or diabetes, that it's manageable, but you probably are going to need medicine throughout your life. But what we found is that there is all different combinations. So some people where we can't cure the disease with resection or cryotherapy, we can get it better, and then they may be able to take a very low dose medicine. The most common one that we see is something called sirolimus or rapamycin. It's a pill that's taken twice a day. And it's been used for many years at much higher doses in transplant, organ transplant like kidney or heart transplant. So it does suppress the immune system a little bit, but at the low doses used for FAVAs, it usually is not a serious concern. That's, of course, with COVID been a big concern. People do have to be surveilled, meaning that you need to be seen every few months and have blood work and a check-in to make sure that, say, your liver function tests and so forth are okay. So that's another piece of things when we sit down with a patient that's very individualized. Some patients may have options of these different treatments, say, if there's a chance that I can treat this without surgery, I want it. I don't want any surgery. I want a medication. And other patients say, look, the thought of having to take medicine for years and have to have ongoing appointments and having a whole body drug, I don't want that. So that's where we really try to offer all the options. What the medical therapy is typically not for focal FAVA. It's for diffuse, widespread lesions that we can't treat another way that, of course, are symptomatic. You're not going to give someone medicine who has no symptoms, because again, it's not cancer.
Right.
So we only are treating people that have symptoms of pain, swelling, contracture,
Okay. And if you have a diffuse FAVA, in your opinion, you'd get more pain relief from a partial resection if you qualify plus medication than just medication alone?
Well, we've got to really, I think that's a question a lot of people are interested in, is how to treat those, because those are the most difficult subset. I think it depends. I just don't think there's unfortunately a clear answer I can give you. I just saw a patient who had a diffuse FAVA where most of the disease was very dilated vessels and very little muscle disease. So I told that patient that I didn't think surgical resection was going to be helpful. And that patient currently is doing pretty well on medical therapy and has also had a combination because of the large vessels of sclerotherapy, closing the big vessels, as well as some cryotherapy. And then there's other patients where I have a patient who had a very diffuse FAVA in both the thigh, the calf, and the foot, who was initially on medicine, wasn't enough, didn't see any response really to cryotherapy, then had a pretty big resection, and now is doing well on a low dose of sirolimus. So we just, again, it's very individualized. We have to see what makes sense in each patient.
Okay, and it sounds like you're saying after you examine them, you could get a pretty good idea of what makes sense for each.
Right. So if someone comes to me and they have no contracture, meaning their joints, like everything bends and straightens, their use of their limb is good, and the nerves are all working, and there isn't really a focal muscle disease, they probably don't need a resection and are better served with my interventional colleague, Dr. Shake's techniques and medical therapy. But there are patients with diffuse FAVA who have a section of the part that is bothersome and can be surgically removed, and we may decide that's helpful in conjunction.
And so we talked about if it's focal, if it's isolated, if you resect it, there's a good chance 5 to 10 years out that it won't grow back. What about people who it's more diffuse and you went in and you resected part of it? We can expect that to start growing back, correct?
Well, I think that's a good question. So that's where I need to really answer that with more research. Some of the patients, I'm now telling them that I think after a successful resection, before the disease grows back, is a good time to start medicine. Mm-hmm. So I have some patients like that who have said, I'm glad you're doing well after my resection, but I know I didn't get it all. And you have some disease right along your nerves. So let's see if you can start sirolimus now under the guidance of my medical colleagues and hopefully not have it grow back. But that's where we just don't know yet what the right answer is. And now the other thing that's important, I really encourage my patients who have any sort of resection to have their tissue genetically sequenced, because that can really guide future therapies. So what is the genetic cause in my FAVA of why it's having its regrowth? So we don't know yet. That's ongoing. You probably have heard that there's a lot of overlap with FAVA and the PIK3CA related conditions. And so some of them are testing positive for the PIK3CA mutation, but not all of them. So I think there's going to be a lot more work in the coming decades, just like there is in cancer, to really genetically sequence someone's lesion, try to understand it. And then hopefully in the future, there'll be better, molecular based therapies that are targeted to whatever the mutation is in that tissue.
Okay. And do you have any insights at this point of what other genetic mutations you're finding for the FAVA patients?
Well, so far it's because they're testing a panel that's related. It's related ones, like PIK3R1 is one that just came up. But what we don't understand yet is what is the precise kind of signaling switch that's happening. Like what are we trying to block, and what's important in different patients? And I think we're going to find that, and this is already very clear in the work we've done, is they're not all the same. So while there are similarities among the FAVAs, as I said, that's why you have to individualize it. There's similarities, but they're they're different between different patients.
Let's say there's a patient and their surgeon says that they could do a resection on them. What questions do you suggest the patient ask before going into surgery?
The first question is just, does that surgeon do this type of surgery commonly, and do they feel comfortable with it? And I think a good surgeon will always tell you, like if someone comes to me and says, well, I'd like you to do my knee replacement. I'd say, well, no, I haven't done those for like 25 years since I was a trainee. So I think you should see an adult joint replacement surgeon and send them to a friend who specializes in that. If the surgeon feels they can do it, the other thing that comes up is, again, that tip of the iceberg concept. So the patient should ask, if the FAVA involves a muscle, are you planning to resect that? Because I think, confidently know now that just doing some of the FAVA tissue around the muscle or on top of it, if the muscle is truly diseased, doesn't help. And so if someone has a FAVA in a resectable muscle, so many muscles have like partners that can do the same job, then I would always say take the whole thing out. That's the best chance that someone has of not having it come back. So for example, like say in the thigh, the quadricep, quad means 4. There are 4 different heads of the quadriceps. If your FAVA is only in one, don't try to guess where it ends, just resect the entire muscle, and there's a better chance of avoiding recurrence. I think that's also important because I have seen patients where it's pretty clear that the muscle disease was not addressed in the resection, and it was just like sort of the surrounding.
Let's say a patient goes in, they have a resection, they have no more pain, they move on with their life after healing. Should they go back and see a doctor or get an MRI periodically, or do they wait until and unless they have pain or other issues?
Yeah, we haven't answered that. I do tell people that I like to rescan the area 1 to 2 years after resection to just look and document. But then if they're symptom free, what often I do with my patients say, hey, can we have a telemedicine check-in, either virtually on a Zoom like you and I are doing, or even just a message like, hey, I'm 5 years out, I'm still doing well. Because that is going to be really important to counsel patients who are potentially choosing treatments. Is like, okay, how many people are actually out there doing well that aren't actively followed? Because sometimes in research, what happens is you have this group of people that are lost to follow-up, and you can make 1 or 2 assumptions usually. One is like, hey, they're not coming back because they're absolutely fine. But the other reason could be they're not coming back because they're miserable and they've gone to seek care elsewhere. And you may not know that. So that's where we're trying to just at least keep track of people. And I think hopefully that's getting easier with telemedicine. And that's where your group is going to be really important to help with that, and all the people who had various treatments and try to sort out what's working the best long-term for them.
And then, so you mentioned sclerotherapy. How does sclerotherapy fit in with FAVA patients and with resections?
Well, in general, we tell patients that most FAVA is not helped by sclerotherapy. So if your FAVA disease doesn't have big dilated vessels and it's solid, which most of them are, and again, there's always exceptions, but most are more solid, that fibro-adipose, fibro meaning scarred and adipose meaning fatty. Most are going to be just doing either the cryotherapy versus surgery and then the medicine. But some do have very large veins and arteries near them that may need treatment, and that treatment, sclerotherapy, means to close those with some means. If they're small, sometimes Dr. Shake and his colleagues can just inject things that kind of collapse the vessel, medicines that make it just collapse and block. And sometimes if they're very large, like they're sometimes like this big, he has to put coils in them to literally plug them up. But I would say that that's more rare. Like probably less than 10% of our FAVA patients actually have very large dilated vessels. There are a subset of patients with FAVA who I've amputated that we just have said, enough is enough. I often call it in FAVA or other vascular malformations, is it what we call a parasitic? So if you have one arm or one leg that's ruining your life and the rest of your other 3 parts are fine, maybe the most sensible thing is to get rid of it, to amputate it. And that if someone is truly got a lot of nerve involvement. Maybe they've already had procedures. They're out of life. Like some of my patients have come in a wheelchair on high dose narcotics, unable to, they're not sleeping, they're miserable, then it can make sense to think of amputation. Some of them have never tried medical therapy. I've seen patients also who were in a bad way and they got better with some of these newer drug therapies. So I really always think there's hope for options. I really do want us to work with you in your patient group. I also feel very strongly that patient advocacy groups like Project FAVA are very important.
Okay, so similar question. It might have the same answer. What about a FAVA patient? They came in, they got diagnosed. They don't really have symptoms, or their symptoms aren't that bothersome. Do you suggest they go in and have checkups with doctors or get MRIs, or just wait until they have issues?
Well, I think they should definitely be followed, and it just depends what the particular FAVA situation is. Because the genetic difference in the tissue will make it keep changing throughout life. I don't think you can say to someone who's, say, 17 and asymptomatic that it's going to stay that way.
Yeah.
So we do try to counsel our patients like, hey, if you start to have pain in the future, you need to get looked at. We have noticed there is a gender predominance of female. About 70% of FAVA patients are female. We don't know why that is. We have consistently seen that in our series. And also we've noticed that for adult women who have biologic children with childbirth and pregnancy, the FAVA can get worse, which makes you think it's got something to do with hormones. We also notice another time period people tend to get worse is the teenage years after they've gone through puberty. And that's true for both men and women. And so I do think that's important to counsel patients about, that it may change later in life. And so if you start to have symptoms, to know where you can find care again and get looked at.
Okay. And if they have symptoms during pregnancy, does it resolve afterwards, or does that tend to be more permanent?
Not always. So sometimes, again, that's where that individual counseling comes in. Sometimes if someone is considering a pregnancy, they may say, I'm already not doing well, and maybe I should have the surgery ahead. But I certainly have a handful of adult women who I've surgically treated after pregnancy, and that's possible too. So we're not recommending ever prophylactic treatment, like just doing something to it because it's there in case it gets worse, because the other thing is some people don't get worse, and we don't know why that is either. So that's why it's so important to just follow people, listen to what their symptoms are, and see if they're getting worse over time or not.
Some people may get worse during pregnancy, some people may not, and some people may get worse, but it'll resolve once the pregnancy is over.
Yeah, and it's just true because since legs are the most common place where FAVA is, most people are familiar that in the later stages of pregnancy, many pregnant women have leg swelling. And so just that can make your FAVA in your leg feel worse. And then once you've delivered and recovered, that should get better. But then there are people who we think the extra hormones, either for puberty or pregnancy, may have made the FAVA grow. It's really just talking through with each patient what they've got and what the possible outcomes are, what the options are, and then seeing what is best for that patient.
What about a person who has FAVA diagnosed, but it's not in a limb, it's in a more delicate area, let's say like near the spine? Can someone like that still have a resection?
Well, again, it depends, because you have to, as I said, judge, is it worth a full curative resection, say if that's going to involve the spinal cord or nerves that are working. So certainly I have spine colleagues here. We haven't had many FAVAs. I have seen some in the paraspinal muscles that I've taken out, like sort of upper back around the shoulder blade and things. But fortunately for FAVA, we haven't seen it. For some of the other PIK3CA related conditions like CLOVES, we unfortunately see a lot of spinal disease. So we haven't seen a lot of spinal disease. I suppose my instinct would first be to say, if someone says I have a spinal FAVA, I'd say, we haven't seen that a lot. Like, let's make sure that is the diagnosis. I'm certain can happen. And then it would be that discussion of if it's symptomatic, is it too close to the spinal cord to freeze or inject? Like, should it be debulked partially? Should you try a course of medical therapy? All those kind of things.
Okay. And then what about a patient who wants to come to Boston to have a resection? What could they expect in terms of how long are they going to need to stay in Boston after that?
Again, highly variable. If it's a fairly simple focal resection, they may be able to travel within a few days. If it's complicated, some people will get a short-term rental and stick around for even a few months till they're really through the initial rehab, make sure the wound's fully healed. We do follow people with telemedicine, so we can do most things with looking at wounds and how your limb or knee or wherever it is moving and how the pain is. We can do that pretty well remotely. But that's where, again, we have the discussion, like if someone can come here, should they come? Should we try to find someone locally who could treat them?
Okay. So that's a possibility too, is you might know someone local that you could connect them to.
Sure. I mean, it's always, I do have a lot of patients who travel, but certainly if I can, I try to find them someone locally.
What about a patient that's been diagnosed with FAVA, but they can't get to Boston for whatever reason, money, insurance, whatever else it is? Do you have any type of program where their doctors could get in touch with you and ask you questions?
Yeah, we do that all the time. Usually the best thing is to directly, the surgeon to whichever type of provider, like if it's a hematologist, I'll usually say, well, I know the basics of the pill therapies, but let me get you to my colleague who can really talk you through the genetic testing and the monitoring and so forth. But for surgeries, yeah, I often talk to surgeons in other places about what they're planning to do. And
give us some hope for the future of resections in FAVA. What can you tell us? Where is it going? How is it going to improve?
Well, I think what we've learned since I started doing them, really the first one I did now was 2007. I think we've surgically learned that it definitely does work, but you have to be careful and honest with your indications as to whether it's going to be curative or hopefully helpful. And when I started doing these, we didn't have other medical therapies. In the FAVAs I treat, they're usually pretty well established and the tissue's very changed. So in the short term, I don't think the medicines are truly going to reverse what's already happened. So the next question would be, could we diagnose them earlier so that before someone grew this big mass that's very painful with a very affected limb, if you could stop it where it was when they were like 3 and it really was not very big and wasn't affecting them, I would say that's the next probably easiest step before we figure out a way to truly reverse engineer what's happened.
So that's interesting. So figure out a way to get them to a center earlier so that you can diagnose them earlier.
I really think that's important. One of the people I saw today had just been misdiagnosed and mistreated, was middle-aged and since the age of 7. So we do see still, even though there's more awareness of FAVA, we see a lot of misdiagnosis and inappropriate treatment. And so I do think we're getting much better sense of what doesn't work. So like if you've got a FAVA of the calf and you are toe walking, it doesn't help to put someone through a lot of aggressive therapy and serial casting and things like that. In terms of resection, I guess my thought would be, I'm not sure that I have anything that innovative to tell you, because once the tissue is changed into this FAVA, which is very different than normal tissue, you can't really do it like arthroscopically or through tiny little incisions because it's so stuck. Like I mentioned, it's so stuck and entwined to the other tissues. But my hope would be that we can understand them better genetically and figure out how you could potentially first keep them from growing back or getting worse. And then hopefully if you could diagnose them earlier, prevent someone from ever getting to a point that they needed more invasive treatments.